Hi, physio students and physiotherapist and physical therapist. We are going to see the physical therapy intervention for pediatric patients. So, physical therapy intervention should address the impairments and functional limitations which are identified during the examination. First, we have to see the flexibility. So, we should use the exercises to elongate all musculature that was found decreased flexibility during the examination. So, most children with cardiac and pulmonary disorders will benefit from side-lying trunk rotation, which will elongate the intercostal. We have see most children with cardiac and the intercostal. We have see what are the exercises we can given to them. So then we have given them lying supine over a ball, which will elongate the rib cage musculature, and it will decreasing the thoracic kyphosis and shoulder protraction. A corner stretch to pectoralis major muscle. Now we have seen the stretches. So another we have target the quadratus lumborum, latissimus dorsi, and rectus abdominis muscle. It's also indicated. So then we have to address the lower extremity muscles which are having attachment into the pelvis, because the position of pelvis will affect the thoracic muscles that have attachments on the pelvis, thus will affect the posture and breathing. For example, if they have a hamstring extensibility decrease because the position of waist, then it will lead to a posterior pelvic tilt, which will increase the kyphosis. The second one is strength. In pediatrics, strengthening exercise should minimize the child's own body and gravity for resistance. To target muscles noted to be weak during the examination, play games that involve upper extremity weight bearing, like wheelbarrow walking or crab walking, lower extremity weight bearing, which is squat to stand to retrieve toys, hopping, jumping, and dynamic trunk stabilization.
The therapist should also remember to strengthen the muscles of inspiration. Inspiratory muscle trainer may be used in pediatric patients who are able to follow directions. This is the device with variable resistance to inspiration. Many treatment protocols are suggested in the literature for inspiratory muscle training. One study found that an effective treatment protocol for adults with chronic obstructive pulmonary disease, which is COPD, to use an inspiratory muscle trainer at 40% to 50% of their maximal inspiratory pressure for 30 minutes per day, 5 times a week for 5 consecutive days. However, no studies have determined the best treatment protocol for children, because now we are seeing pediatric cases. The therapist should evaluate each individual child to determine whether inspiratory muscle training may benefit him or her. So then we are talking about posture. A child's posture is affected by the child's muscle flexibility, strength, and thoracic mobility. We have to consider the three things. Therefore, addressing these items earlier in the chapter have an indirect effect on child's posture. The therapist use a mirror during the therapy to provide visual feedback to the child regarding his or her posture. Manual facilitation of spinal extensors during standing and sitting are also effective. Postural training should be incorporated into the child's daily activities so that the greater carryover of postural changes when the child is not in therapy will happen. For the child with neuromuscular weakness, one must be also consider the child's posture in the stroller, car seat, and wheelchair. It is important to make sure the child is supported in a proper alignment so as to prevent or delay the onset of scoliosis or other thoracic deformities. Temporarily, blanket rolls or pillows can be used to aid in supporting the child. However, if there is weakness or increased tone that is expected to be long standing, adaptive equipment may be necessary. So then we see the breathing pattern. Children who have had difficulty breathing for a long time have learned to overuse their axillary muscles. Some children also learn to breathe shallow and use of axillary muscles to decrease thoracic expansion, secondary to pain from an incision. So, in both instances, the therapist has a responsibility to train the diaphragm and intercostals to be the prime muscles of inspiration. So, we should train the so in both instances, the therapist diaphragm and intercostal. So, in young children who have not practiced the inefficient breathing pattern for a very long, so we should use visual cueing to encourage diaphragmatic breathing. With a child in supine, with a child in supine, place a stuffed animal on a child's abdomen. Tell the it's an animal toy. Tell the child to take the animal for a ride by making it go up every time the child takes a breath in. In the older child, manual facilitation techniques such as quick stretch and tactile cueing of the diaphragm and intercostal muscles may be necessary. Another technique to inhibit the axillary muscle during inhalation. This should be attempted last as it is a more uncomfortable technique for the child. Once proper breathing pattern is obtained while supine, the child should attempt to maintain this pattern while sitting. Once the child can maintain the pattern in sitting, then it to do it in standing. With each of this progressively harder position, the child may require repetition of the facilitation techniques. It is important to then incorporate the desired breathing pattern into functional activities. When performing ROM or strengthening exercises, add breathing as a component. Inhalation should be paired with extension and exhalation paired with flexion. So then airway clearance techniques. So chest physical therapy is also known as bronchial hygiene. Chest PT traditionally consists of postural drainage, percussion and vibration. We have to remind in a mnemonic like PPV. So, for an in depth description of all airway clearance techniques and modalities, we have to upload a new video about this. So, then the postal drainage component allows gravity to assist with moving up mucus up to a larger airways. This typically involves the putting the patient in a Trendelenburg position, which is the head is lower than the hips. So, here the Trendelenburg is different. So in pediatrics, however, Trendelenburg position is not always an appropriate position. So the lower esophageal sphincter is not strong enough until 2 years of age to prevent reflux in this position. So therefore, the therapist should never use or recommend the Trendelenburg position in a child who is younger than 2 years old. So additionally, it has been shown that older child with CF, which means cystic fibrosis, may reflex and silently aspirate with no observable signs. So, although other studies show that modifiable postural drainage positioning, that is Trendelenburg position with only 20 degrees of head down, is safe to perform with children who have CF. Okay, then when performing a CPT, which is a chest physical therapy with infants or young children, the child is often more comfortable receiving this chest physical therapy in the therapist or patient's arms. Singing songs and reading books during chest physical therapy can also improve the child's tolerance of the procedure. This population is also likely to fall asleep during CPT if it's time for a nap. So it is preferable for the child to stay awake and perform after chest physical therapy so as to facilitate a cough or sneeze to clear the airway. However, sleeping baby does not need to be awakened to attempt facilitating coughing. So we have to keep in mind this. Then high frequency chest wall oscillation. So high frequency chest wall oscillation is a technique for airway clearance that has been used since 1988. For this technique, the patient dons a vest that contains an air bladder. A generator attaches to the vest via one or two hoses depending on the model used. So now variety of models came up. So the generator uses air to inflate the vest and then provides high frequency burst of air into the vest. So this burst create shear forces on the chest wall and into the lungs that decrease the viscosity of the mucus and aid in mobilizing the secretions up to larger airways. So there are no guidelines for patient age at initiation of this vest use. The vest companies have made very small vest to fit even a 1 year old with CF. Many CF centers in US will wait until a child is closer to 2 years old to begin using the vest. So, absolutely contraindication for usage of this high frequency chest wall oscillation is unstable head, neck, rib cage, or back injury, or an active hemorrhage. So, relative contraindications for usage of this high frequency chest wall oscillation is subcutaneous emphysema, recent epidural spinal infusion or spinal anesthesia, so recent skin graft or flaps on the thorax, burns, open wounds, and skin infections of the thorax, recently placed tr- transvenous pacemaker or subcutaneous pacemaker, suspected pulmonary tuberculosis, lung contusion, bronchospasm, complaint of chest wall pain. So then our management is positive expiratory pressure. So this positive expiratory pressure devices provide a resistance to exhalation. So this pressure during exhalation splints open the airways and facilitate mobility of mucus through open airways. Some PEP devices that are sold provide only PEP. So some other devices provide oscillation with the positive expiratory pressure, which is called as oscillatory PEP, oscillatory PEP. Acapella and flutter are two of these devices. So a flutter uses a steel ball that vibrates inside a cone to provide the oscillations. It requires that the device be held parallel to the floor in order for gravity to apply correct forces on the ball. The acapella provides oscillations as air passes over a pair of magnets. This device is not gravity dependent and can be performed in any position. Although they produce similar levels of PEP and oscillations, the acapella may be more effective clinically to ease of use. So, for younger children, therapy is always more effective when it is fun or incorporated into a game. So, bubble PEP is a method of providing PEP with some oscillations. A container filled with water to the level of desired pressure, example 10 centimeter of water. Suction tubing is cut to place into the container as the straw. So the child then blows into the straw and create bubbles. So the water provides the positive expiratory pressure and bubbles provide the oscillations. If soap is placed in the water, the child will attempt to make the bubbles come out of the top of the container. So this provides an incentive to continue to blow. Once the bubbles come out of the container, the child can play with the bubbles and then try to make more bubbles once those are gone. So then blow toys. Adults are able to use an incentive spirometer 10 times every hour in order to take deep breaths and keep their lungs clear after surgery or when lying in bed for prolonged period. Children are not often cooperative with the incentive spirometer, so there are many toys for children encourage deep breathing, that is kazoo, party blower, noisemakers, pinwheels, bubbles. So giving a child a couple of toys to work on blowing can be an effective encouraging deep breathing as an incentive spirometer. Playing any blowing games can be effective. For instance, placing a cotton ball in the middle of a table, the child stands on one side and the therapist stands on other side. The person to blow the cotton ball off the table on their opponent side wins. So next is huffing. So huffing is also referred to as forced expiratory technique. So the child uses low to mid lung volume to force the mucus into larger airways. As the mucus move up the airway, the huff becomes more forceful. So this technique is designed to move the mucus with less risk of dynamic airway collapse than deep strong coughing. Huffing should be performed after any airway clearance technique to aid in expectoration of the mucus. Then assisted cough. When a child does not have a strong cough, like common in cases of neuromuscular weakness such as SMA or muscular dystrophy, secretions may build up in the child's lungs. So, parents or caregivers may be instructed how to assist the child with coughing to increase pores generation. To perform an assisted cough, the therapist places his or her hand on the child's abdomen just below the diaphragm. The child takes a large breath in and holds it for 1 to 3 seconds. The child then attempts to cough as hard as the child can. The therapist provides compression with an upward thrust in the direction of diaphragm. When manually assisted coughing is no longer enough to clear mucus secretion, the therapist may try a cough assist machine, which is shown in the image. It gradually applies a positive pressure to the airway, then rapidly shifts to a negative pressure. The rapid shift in pressure produces a high expiratory flow, stimulating a natural cough. The cough assist machine can be used in isolation when a child has mucus to clear in the trachea, or it can be used after another form of airway clearance to assist in clearing the loosened mucus. So, we have to say about previously. So, choosing the most appropriate airway clearance technique. So, the best choice for airway clearance varies on the individual patient circumstance. For instance, if the child has a floppy or reactive airway, a form of PEP may aid in keeping the airway open during mobilization of mucus. So, the best plan for home airway clearance is always give the child and family options. Family should know how to use a few techniques and choose the most appropriate one which is fit into their current life situation. And when a child presents with increased tone, the muscles of thorax are also affected. So utilizing methods to reduce tone allow the child to breathe more easily and allows the therapist to use manual techniques to facilitate proper breathing mechanics. Various tone inhibiting techniques may be used, include positioning the child in flexion of his or her extremities and trunk, rhythmic rocking, dissociating extremities, and decreased external stimulation, which is loud noises, bright lights, television, and sibling sounds.